I'm Nick Cheshire and this is VEITH 2019. I'm pleased to say I'm sitting here this morning with Professor Andrew Bradbury, and we're going to be speaking about the UK NICE guidelines for aortic aneurysm repair. Andrew, you're the chairman of the guideline committee.
That's correct. Yeah.
What messages would you like to give out to the important stakeholders about the guideline? Let's talk about, say, patients and their families first.
Yeah. So as you know, the draft guideline was published in May, June of last year, and we got quite a lot of pushback from some of the recommendations. Many of them went through unchallenged, but you know, the recommendations around EVAR were controversial. And what I would say that NICE and we as the guideline committee have taken all that on board, and we've done a lot of work to try and respond to those criticisms, redoing the modelling, redoing the way that we present the guidelines with a more patient focus. There's a new section on patient information, for example. And that's one of the reasons it's taken so long to get it out, because of all that work that we've done. So we've taken all that very seriously. Obviously, it's very important that it leads to a change in practice that benefits patients and also our National Health Service. And I think we're quite near the end of that process now, I hope.
So if my father was waiting for an aneurysm repair and I called you to say what's going to happen to him with regard to your guideline, what would you say to me as a family member?
I think what I would say is that guideline will give good scientific evidence that your father is likely to be better off with an open repair than an endovascular repair, depending on his particular circumstances, obviously. But the general direction of travel is towards open repair and away from endovascular repair.
This kind of large change in practice or policy even certainly requires important stakeholder groups like us surgeons to come along with you. And where do you see you are with bringing the surgical fraternity in the UK along with this?
Well, there is a group of surgical colleagues who are implacably opposed to anything that changes, business as usual. But there's also, I would say, a bigger group of people who understand that there needs to be some rebalancing of practice. And I think what we can see in the UK, even though the guidelines are only out in draft, it's opened a lot of discussion and dialogue about the issue. And we see, for example, from the National Vascular Registry, there's already beginning to be a bit of a rebalancing back towards open surgery. There's not going to be some seismic overnight change, obviously, when the guidelines come out, because there'll be an implementation phase. That's something NICE are very used to. So there'll be a transition phase from where we are now to where we want to be in maybe a couple of years' time, I think.
Lively discussion is one way of describing it.
Yes.
Stiff criticism is another way of describing what you've received for your work. How have you handled that personally?
Well, I think, as we both know, in academic vascular surgery, you've got to have a fairly thick skin, and you have to just accept the rough and tumble. Some of the criticism I've had has been quite personal, both in public and private, and I understand why certain people are cross about it, and obviously, since I'm the chair of the committee, it tends to be directed at me. I don't take it personally. I think it's been a worthwhile thing to do, and it's been uncomfortable at times, but I like to think that the guideline committee that I chair has made a positive change towards improving patient care.
And how influential are you in your role as the chair of the guideline committee? NICE has got a very distinct processes, doesn't it? But obviously.
So I was the first person so they appoint the chair first, and then we appoint what we call early members, and I am involved in the appointment of the committee, but it's largely driven by NICE. My job is to chair the guideline committee meetings, of which I think we've had 18 so far. So I'm a bit like a referee, trying to keep the play going. Do I personally, as chair, have any more influence over what the output is than anyone else on the guideline committee? No. And NICE are very particular in they have very strict policies and procedures to make sure that certain key individuals don't bulldoze their way through and get their way over and above what the committee wants to do as a group. And of course, the other thing is important to know that we've had patients on the committee with lived experience of both open repair and EVAR, and that's an important thing to emphasise.
Sure. You've obviously put a lot of work into this. Has it given you any thoughts about where aortic aneurysm repair is going to go or should be going?
I think we probably have to see the NICE guidelines in some sort of context. We know that the prevalence of the condition is falling, at least in the UK, and is likely to continue to do so at an uncertain rate, but the trend is likely to be downwards. I think we know that aneurysms don't grow now as fast as we used to think that they did, and that's led to some extending of surveillance intervals. And I think we also know from the screening data that Jonathan Earnshaw has presented that the rupture rate is also a lot lower than we were taught when we were registrars.
Yeah.
And whether that's because we overestimated it or whether with best medical therapy and stopping smoking and general better levels of health, that's made a big change. So I think we have to recalibrate intervening or not intervening in aneurysms, taking that new information into account. And then the secondary thing is, if you do think a patient would benefit from an intervention, it's then which way do you go, which is where I suppose the NICE guidelines come in.
Yeah. Okay, well, Andrew, thank you very much for your time.
Thank you very much.